Hello dear aspirants, let's quickly review about the updated neonatal guidelines that was published by the American Academy of Pediatrics in October 2025. Actually, the overall guidelines remain unchanged, but they have done some minor changes in the guidelines. Let's review them by one. First one is initiate cord management plan. Earlier, there is no such provision of cord management plan in the algorithm, but they have added now. For stable term and preterm baby, delayed cord clamping can be done at least 60 seconds. Earlier, it was 30 to 60 seconds. And for non-stable baby, such as non-vigorous babies who are born between 35 to 42 weeks of gestation, you can do umbilical cord milking instead of delayed cord clamping. However, baby who born less than 28 weeks of gestation, you can't perform umbilical cord milking because this may increase the risk of intraventricular hemorrhage in those babies. And second one is suctioning. They have removed routine suctioning from the initial steps. Instead, they mention that clear the airway if needed only. Okay. And third one is ventilation and ventilatory corrective steps. The term positive pressure ventilation has been replaced by just ventilation. And the ventilation target has been increased from 30 to 60 breaths per minute. Earlier it was 40 to 60 breaths per minute. Timing also has been changed. If the baby's heart rate is not increased after 15 to 30 seconds of initiation of ventilation, you can do corrective steps, ventilatory corrective steps as per your like. There is no need to follow Mr. Sopa order as per this update. Earlier, this timing has been only limited to 15 seconds of initiation of ventilation, but now they have increased the timing from 15 to 30 seconds. And fourth update is LMA and CPAP. For term baby who are apneic or gasping, you can go with LMA mask, just laryngeal mask airway to provide airway. Now they have included in the algorithm this LMA as a primary device for providing oxygen to this term baby who are born after 34 weeks of gestation. For preterm newborn who are breathing spontaneously but having increased workup breathing means you can consider CPAP. The CPAP may be beneficial for the preterm baby. Fifth one is oxygen supplementation and oxygen saturation. Ventilation of the baby may initiation with 21 percentage of FiO2 if the baby is greater than 35 weeks of gestation. If the baby is 32 to 34 weeks of gestation, you can use 21 to 30 percentage of FiO2. If the baby is less than 32 weeks of gestation, the FiO2 level should be 30 to 100 percentage. They have clearly mentioned that for smaller baby, greater FiO2 will be beneficial to the baby. And about oxygen saturation level, the 1 minute oxygen saturation level has been removed from the table. Now the table starts with 2 minute oxygen saturation level, but the SpO2 level remain unchanged. And the sixth one is chest compression. If the heart rate remains less than 60 per minute, despite of 30 seconds of ventilation, chest compression should be provided. The preferred method to do chest compression is two thumb encircling hand technique, not the two finger method. Now, the two-finger method has been eliminated from the guidelines due to its ineffectiveness. And seventh one is epinephrine. If the heart rate remains 60 per minute, in despite of 60 seconds of chest compression and adequate ventilation, epinephrine should be administered ideally via umbilical venous catheterization or intraosseous route. Endotracheal administration of epinephrine is not preferred until if the intravascular route such as umbilical venous or intraosseous route is not feasible, you can go with endotracheal administration of epinephrine. And eighth one is endotracheal tube size and depth analysis. Updated endotracheal tube size based on weight and gestation age. If the baby is born between 22 to 25 weeks of gestation or less than 800 grams, you can go with 2.5 mm size of endotracheal tube, or you can use 2 size also. If the baby is born between 25 to 28 weeks of gestation or 800 to 1200 grams of weight, you can use 2.5 mm of ET tube. The baby is born between 28 to 34 weeks of gestation or weighs about 1201 to 2200 gram means you can use 3 mm of endotracheal tube. Or if the baby is born after 34 weeks of gestation or weighs about greater than 2200 gram of weight, you can use 3.5 mm of ET tube. About depth analysis, the upper gum, that means anterior edge of the maxillary gum, is the point of reference instead of lip. Earlier, the baby's lip is the point of reference to analyze the depth of the ET tube size. Now it is upper gum. I hope you all understand these guidelines. Thank you for watching. Keep supporting me and share this video to your friends who are confused about updated neonatal guidelines. Thank you, friends.